Thank you very much, Peter. A critical member of the sports medicine team, whether you're a surgeon or a sports physician, is the radiologist. And it gives me great pleasure to introduce our Chief of Radiology here at Aspetar, Dr. Emad Al Musa, who trained and had experience in the universities of Pittsburgh and New York universities. His talk is on the value of MRI in predicting return to play.
Thank you, Steve. Assalamu alaikum, everybody. I want to thank the organizers and everybody here, and a special thanks to Dr. Nebu Popovich for inviting us and having radiology speak at this moment. So I'm going to talk a little bit about MRI and predicting return to play. Peter just touched upon it with high ankle sprains and stress fractures, and you could see that the CT scan, the imaging findings lag significantly behind clinical findings. So I have no financial relationships to disclose. So a brief outline of what I'm going to talk about, give you a little bit of an introduction to diagnostic examinations that are available out there, and then get into MRI and predicting return to play, tell you what's out there. So return to play is a difficult decision process to make. You can ask the sports medicine physicians. I believe it's a team effort involving several clinicians, whether they're sports medicine, physiotherapist. You can also find in this mix the coach, the owner of a club, so there's a lot of pressure on when this player is going to return to play. And there's definitely going to be a difference in opinion and lack of unanimity on a decision of when a player can come back to play. And I think the final decision should fall on the sports medicine physician. And MRI should just be looked at as a small piece in a big puzzle. This return to play decision lacks any standardization, and the key point is imaging is just another tool that can be used in the big picture. So this is the strategic assessment of risk and risk tolerance, the START framework, which shows how complex this seemingly simple decision can be. And you can see by the black arrow depicted that imaging or lab tests is just one small part in this whole process. This is viewing the return to play decision through an evidence-based model by Creighton. And again, this is just showing you the black arrow depicting that imaging is just one more tool that you could use in that process to make the decision. So a little bit of the epidemiology, not going to get into it too much. There was a 12-year study of European professional soccer athletes showing that 95% of all muscle injuries fell into 4 groups, whether it was the hamstring, which accounted for about 34% of them, the adductors 21%, the quads were 14% of the muscle injuries, and the calf was 12%. So what are the diagnostic imaging tools out there? The plain film should be the first imaging choice of any injury or any examination ordered. Just start off with the plain film. It can give you the answer and also guide you sometimes in the diagnosis. This is a 24-year-old footballer with a previous history of trauma. You can see that the patient has a mineralized mass in the soft tissues adjacent to the distal femur. There's a separation between the cortex and the mass. The coronal T1 weighted image shows a heterogeneously enhancing mass. Given the history and clinical imaging findings, this would go along with myositis ossificans. This would be a difficult diagnosis to make if you didn't have the plain films. It could look like an aggressive tumor or something bad. So I'm going to focus now on the MRI. I think this was a great paper by Ruring in 2014 in Sports Medicine, which at that time had summarized everything with regards to MRI and return to play that was out there. They looked at all the studies and assessed them for risk of bias and the number of supporting studies, and concluded that there's considerable risk of bias in everything that was out there except for one study. A nice thing they did also is they looked at all the parameters that you could look at with regards to imaging and predicting return to play. So they looked at where there was an MR negative injury, number of muscles involved, the muscle involved, tendon involvement, whether it was the myotendinous junction, the volume, the cross-sectional area, fluid, and grading. And what they concluded was that there was, from all these studies, there was moderate evidence, and moderate was one study with a low risk of bias, or 2 or more studies out there with a high risk of bias. So there was moderate evidence, only moderate evidence, that injuries without edema or the grade zeros, I apologize. Yeah. There's moderate evidence that the muscle injuries that were negative on the fluid-sensitive sequences predicted a shorter return to play. And there was moderate evidence that there was a longer return to play if there was tendon involvement. Also, they had moderate evidence, depending on which muscle was involved, in predicting return to play. Another couple of great points that they had brought up was that the definition of return to play varied from all the papers out there. What was return to play? Was it return to competition, return to rehab, return to training, return to match selection? And how long was the return to play? Was it meaning just getting back to play 2 games and then just finishing the season, or completing an entire season? And they went into the mechanism of injury, whether it was a stretch injury or a sprinter type injury. And these were the articles that came after that. You could see that there's several articles published after that Rurinc article discussing return to play and predicting its value, MR imaging. Okay. So here was the use of MRI. They looked at this with the Pitrin's classification, which is a grade 0, which most of us will know out there is a negative MRI. Grade 2 is muscle edema without the disruption. Grade 2 is a partial tear, and grade 3 is a complete. So these guys showed that grade 0s had about 8-day return to play, plus or minus 3 days. The grade 3s approached 73 days time off, plus or minus 60 days off. Then they looked at the MRI and return to play with the central tendon involvement. So Dr. Komen et al. In American Journal of Sports Medicine published in 2013 this idea of the central tendon. So you can see here, there's a free tendon, and then the tendon, the proximal tendon, runs about mid to distal third of the femoral shaft. The distal tendon extends about midway up the femoral shaft. But that tendon takes a long course, and disruption at any point they predicted was a higher return to play. And they concluded if the central tendon was disrupted, it was about 72 days off before they returned to play. If it wasn't injured, it was about 21 days to return to play. So here's a 27-year-old footballer with a suspected hamstring injury. You could see a moderate grade injury at the proximal myotendinous junction of the biceps femoris with disruption of the black tendon there. On the axial fluid sensitive sequence, you could see the same thing, the moderate grade injury with disruption of the tendon. This, you can give you a clue to the doc. I'm not going to say that it's going to be the final decision to return to play, but it gives the doctor an idea that this is going to probably be a little bit longer for the guy to return to play than a non-tendon involvement. So in 2014, in British Journal of Sports Medicine, Pollock, they came up with a new classification system, which was 1 through 4. But the main idea behind this was they added location into the grading system. If it was myofascial, they put it at A. If it was myotendinous, they put it at B. If there was tendinous involvement, they put it at C. So it goes back to that idea of the tendon involvement, but they put it into their classification system. So Eekstrand in 2014 in Sports Science prospectively analyzed 89 European football teams from 2001 to 2013, and they predicted about the same from previous studies, that a grade 1 injury was about 18 days off, plus or minus 15. Grade 3s were about 60 days off, plus or minus 57. But the nice thing is the grade 0s, all of them concluded it was about 6 to 9 days off before the return to play. So here's a 31-year-old athlete. It's not going to guide the decision into the return to play, but the clinician was suspecting grade 2/3. This, you can see that there's a complete tear of the hamstring tendons from the ischial tuberosity attachment. There's a fluid-filled gap measuring about 4 centimeters. There's no bony avulsion. You can see on the axial fluid-sensitive sequence, there's a complete tear. It's not going to be the final decision maker, but you could tell the clinician what's going on, and it will give them an idea, and they can give that idea to the player or the coaching staff. Here's another example. This is an athlete with a suspected injury. The question was it a grade 1 or grade 2 tear? You can see that there's the feather edema at the proximal myotendinous junction of the biceps femoris. That's going to be the grade 1, but you also see the tear and disruption of the central tendon. So you can give the clinician that this is probably going to be a longer return to play than a simple grade 1 or grade 2 injury. So from the same study by Eekstrand in 2014, they took results from the quads. And here at Aspetar, I think Dr. Frank Van Helmont is putting together and analyzing some data on the return to play with regards to quad injuries. But these guys, this is the only paper I could find down there with regards to the quads. They found similar results with regards to the hamstring, where the grade 1's about 14 days off, the grade 3's approaching 79 days off for the player. The rectus femoris, so which muscle involved would help predict return to play. Rectus fem had a longer return to play than all the vastus muscles. And then the final thing they concluded in this paper, not much in the groin that you could find for return to play, but these guys said that the groin had a shorter return to play than all the other muscle groups studied. So this was an athlete who had an injury, complete tear at the proximal myotendinous junction of the rectus femoris. It looks like it involves the direct and indirect head. You could see that on the sagittal fluid sensitive sequence, there's a complete disruption with a fluid filled gap measuring about 2 to 3 centimeters in size. Here's the axial sequence. You could see that the indirect tendon, and here's a diagram depicting this. The blue would be the indirect tendon. It takes a dive into the muscle belly. The direct tendon stays superficial. So you could see that this is going to be a high-grade injury at that proximal myotendinous junction with tendon involvement. And if you could take the data that you found from the quads and, from the hamstring, if there's central tendon involvement, this is probably going to be a longer return to play than a simple muscle injury. So that was kind of supporting return to play. This is published in British Journal of Sports Medicine in 2015. A research group led by Arnlong Wangenstein here at Aspetar found that the additional predictive value of MRI was negligible beyond that based on physical exam and history alone. They said that physical exam and history accounted for about 29% of the total variance, and MRI only added 2.8% additional value. Ruhrink and researchers from Aspetar published in 2013 that functional testing was more accurate in predicting return to play than MRI. But another thing they found interesting also was at return to play, how many MRIs showed persistent abnormality. And they showed almost 89%, up to 90% of patients who returned to play still had abnormal MRIs. So this goes along with what Peter was discussing earlier. The imaging findings in almost everything, whether it's infection, fracture, muscle injury, it always lags behind the clinical findings. So it shouldn't be used as the basis for return to play. Here is an example. This was a 19-year-old athlete. This is courtesy Dr. Juan Alonso here. He's a track and field athlete who sustained a high-grade injury at the proximal myotendinous junction of his hamstring. You can see it's a complete rupture with a fluid-filled gap there. This was pre-return to play. So he injured in April. This was his MRI in November. If you looked at this alone, you would say that there's no way this guy's going to compete. Here's another example, also thanks to Dr. Juan, track and field athlete who injured his groin, and this was an MRI 3 days before competition. You can see a complete avulsion of the adductor longus tendon from its symphyseal attachment. It's a grade 3. This guy went on to compete 3 days later and medaled. So the same paper with Ruhrink, they found that fibrosis was present in 34% of the patients that went to return to play. And they concluded that there might be an increased risk of re-injury with patients who had fibrosis on return to play. 5 out of the 53 had a re-injury. So here's an example of a patient who sustained a hamstring injury about a year ago. You can see the markedly thickened semitendinous tendon. So that's the scar. You can see on the axial sequence, the red arrows depicting the thickened, scarred semitendinous tendon. But immediately subjacent to it, you see the feathery edema involving the semimembranous with some disruption of the fibers. So that's a grade 1-2 injury of the semimembranous adjacent to the previous injury. And the final thing I'll just touch upon is one of the only papers I found on soleus injury. So this is a new topic that's pretty interesting. This is from Barcelona, Pedrat and Company. They published this in 2015. And what they concluded is if there was central tendon involvement in the soleus, this predicted a longer return to play. They put, if there was central tendon involvement, it went up to 44 days versus non-involvement was at 25 days. And here's an example from Dr. Balios. You can see that this calf strain involving the soleus, you can see that there's disruption of the central tendon versus this injury which involved the medial aponeurosis. This was predicted a longer return to play than the one on the right. So to conclude, return to play decisions are considered the responsibility of the team physician, and I think they could use all the information they can get in making this difficult decision. I'm not saying MRI will ever replace that and shouldn't replace the clinical picture, and it should rely on functional tests and pain scores. But MRI can help in that diagnosis and give something in black and white to a team physician or a coach or an owner to show them what's going on with their player. And just to conclude, a little word from Henry Ford. Thank you.